for your work as well as your presentation. I'm well aware of the hard work that was done by the various committees, but to hear you present this today is very, very encouraging that we're on the right direction. Thank you so much. We have lots to do, lots more to learn, but I'm very heartened by the fact that we are doing the best that we can. Any questions for her? Any comments?
I have a question. Can you hear me?
Yep.
Yeah, thanks. That was a great talk. Did many patients actually go home for comfort care with COVID?
No, not many. We were able to find places for them to go, mostly within the hospital area, but we were squeezed. We were getting to the point where we were going to have to look for out of hospital placement for them. Fortunately, it didn't get to that point, so we were able to keep them here unless the family felt strongly about taking them home.
Yeah, I mean, I think that caring for someone dying of COVID with a respiratory illness like COVID would be pretty difficult without a really robust hospice, system in place. And so, and we certainly don't have that where I practice. And I was just curious if that works very well in Rapid City area.
That being said, we do have a lot of folks going home who terminal diagnosis is COVID, but after an extended period of time, typically they're not, at the initial presentation where they're in respiratory distress and that sort of thing. Typically they've been stabilized to at least a certain degree, and then the family's able to take them home. So yeah, no, fortunately we haven't had to send anybody home who was in significant distress.
Okay, thank you.
Rob, any comments?
I have a comment or maybe a question. I'm not sure I can articulate it that well, but I noticed that especially in like cities that had more than one hospital, it seemed like at the beginning of the pandemic, there was a lot of talk about tents and National Guard and external resources. And I saw those kind of dwindle towards the last surge or the Delta. And I wondered if there was any talk or opportunities to take those triage protocols outside of the hospital borders and look at more at a community level. It seemed like there could have been untapped volunteer specialists that may have been retired, or nurses that it seemed like there was a lack of organization beyond hospitals. We were all kind of operating in our own silos to some extent.
I think that our hospital administration, at least, speaking for Rapid City, our hospital administration was working really closely, for instance, with the National Guard, to make sure that those protocols were broadly applicable, that everybody was getting the same level of care, regardless of kind of where they presented and where they were sent. So I think that they were able to coordinate that.
Hey, Kathy, this is Kelly Stacy. We actually worked a lot with the National Guard, like Andrea's saying. They helped out quite a bit with our COVID testing. We have 2 urgent cares that really became the sites of non-facility testing, because we used them in the parking lot because we initially didn't want them in the buildings. And we had some tents set up. We actually had some trailers. We've talked about tents a lot, like with the emergency department. We did have some places where we used those kind of things. The other thing we did a lot with is, once we started getting vaccinations, we had a lot of retired nurses would come and help give vaccines. We had a couple places that we used it. One was the old Herberger. I don't know if you've been at the mall here. We had a huge area where Herberger's was. So we rented that. And then with this last kind of go around with the boosters, we rented a smaller area. And we had a lot of retired nurses come back. A lot of them didn't want to come into the hospital and take active care of patients, or care of active patients, I should say. But we had multiple people come and volunteer and say, hey, we'd like to help. This is how we can do it. We had a few nurse practitioners who came back out of retirement that helped with some of the vaccines. And so I think in the community here, we had a lot of people that said, hey, I don't want to take care of active care, but I am happy to do what I can do. We had a lot of support from the community. Schools were sending things. We had a lot of restaurants that were sending things to the hospital. So I think we actually had the PR people in a couple of groups working with us to make sure we had some coordinated effort of anybody who wanted to help, how they could help.
Great.
Priscilla had a comment in the chat here. Nursing home providers discuss goals of care with patients and families before ever sending them to the emergency department. Priscilla, I don't know if you want to expand on that, or Dr. Baier?
Well, when we heard the pandemic was coming, and I was on the ethics committee and heard about the triage protocol, and I thought this really underscores the need to have goals of care discussion with our chronically ill patients before we ever send them to the emergency department. So we made a conscious effort. I'm part of a nursing home practice that was taking care of about 250 patients in Rapid City at that time. And we made a conscious effort to work with the nursing home staff to reach out to patients or their families, their surrogate decision makers, and find out what they would want done in the event that their loved one became ill, because many of these patients have comorbid conditions that would make their prognosis poorer. And so the emergency department actually never saw a lot of the COVID patients from the nursing homes. And I think that helped relieve the strain on the hospital system, as well as the strain on the patients who would have been lying in the ER in all that commotion and unfamiliar surroundings.
Yeah, and I'll just make one other comment. On the other end too, once they were in the hospital and critically ill, and you knew that they probably weren't going to live, in addition, we found helpful to have even our administrative assistants that did video conferences and stuff, helping, set up a FaceTime with the family or with their primary provider, getting them connected back to their family or their internist or their family practice doc or APP. I mean, just to see that familiar face. Sometimes decisions were much easier. Well, they were always much easier, I think, for the family to make when they, could connect better with the patient. And we just simply didn't have a lot of time to set up those meetings. We were all pulled in so many directions.
That's a great idea. And I'm sure it was helpful and reassuring to patients and their families too, to have that familiar person for them. So that's really smart.
I enjoyed this. It was to reminisce over those initial talks that we had similar meetings and Brookings with Kathy and some of our staff there, and all of the concern that we had about how many ventilators do we have is it's almost amusing to look back at, because it was always staffing that was the problem, right? We were never going to be able to double our bed size like we planned on, and all of these extra things. It really was a learning exercise to remind ourselves that our people, our trained people, are really our most limited resource. Thank you.
Very true. Oh, thank you. Yeah, no, and that's so true. And I think that will really serve us, as I think we can all assume there's going to be another pandemic at some point in the future. And I think now we're going to know a lot better of what to expect and how to react. And you're right. It's funny to look back at how much we obsessed over ventilators.
Any additional questions or comments? Again, thank you, Dr. Baier. Thank you so much for your presentation. If
Thank
there are
you
no
for having
announcements,